all know, at least from your embryology, that what are meant by congenital heart disease, because heart is one of the organs that has a large tortuous course in its development, and in this process, naturally, it can have certain changes. Furthermore, the heart changes at the time of birth, that is actually from the intrauterine life adapting into the extrauterine life. There are certain changes that need to be occur. So wherever changes need to be occur, there can be always a chance they could go wrong. So based on that,
recording in progress.
So what will happen is that it can have a defect in its process. Now so the main thing is the embryological origin, which of course you all know. I will just recap it. Common anatomical lesions in congenital heart disease and clinical presentation. Very briefly, I will try to go through the clinical component. Now, this is the commonest single group of structural malformation seen in humans, because it can be about 6 to 8 persons per 1,000 live births could have this. So that means about 0.8% children, or almost 1 in 100, closer to 1 in 100 children could be having a congenital heart disease when they were born. So that is the epidemiology of this condition. So etiology wise, of course, you know, now this is a condition which grows so in this process of development, if there are any outside factors, then they can disturb that, and then as part of that, the defect can occur. Now there are these tetragens, which are various extraneous material. The tetragens can be chemicals, medicines, or even it could be actually infections. So the main tetragens, warfarin, anti-epileptic drugs, if the mother had been taking, then other conditions like rubella in the mother, then if the mother had gestational diabetes, and other chromosomal abnormalities in the baby, that is like trisomy 21, which is Down syndrome, then Turner syndrome, that type of conditions, inherently, they do have characteristic defects. So not that everybody gets these defects, but more of those defects are available, seen in these particular conditions. For example, in trisomy 21, you get what is called the AV canal defect, that the cushion, both involving the ASD and a VSD, will be resulting in that, could be there. Then in Turner syndrome, you can get right heart defect, left heart defect, especially there can be aortic coarctation of aorta. Like that, conditions could be there. So when we just recap the normal development of the heart, you know that there is a tube which has indentation, then it folds on its own. So the main two ends of that tube will become, one end will become the venous end, the other will become the arterial end. So the aorta, veins, the atria and the sinus venosus will be there on one end, whereas the other end, there will be the ventricles opening into the truncus, or actually giving rise to the aorta and the great arteries. So ultimately, the main heart will look initially like this, and then of course, so this will be the functional heart during the intrauterine life, where because there is blood coming from the placenta, passing through the liver, and then going into the IVC and entering into the right atrium. And that blood is actually, in the fetal life, is the most oxygenated blood in this body. And it directly goes through the foramen ovale into the left atrium, left ventricle, and then to the aorta. whereas part of the blood will enter into the right ventricle, especially the superior vena cava blood, and then it will come out, and then it may partly go to the lungs, but of course a negligible amount, but most of that will enter into the aorta or the descending aorta. So you can see the blood here in this part would be most oxygenated, then less, then little more less, and then in the ascending part of the aorta, it is relatively low, but the descending part of the aorta becomes further less in oxygenation, because oxygen saturation, because there is mixing of deoxygenated blood, and then part of that blood which is deoxygenated will be going to the placenta, the two umbilical arteries pumping the blood out, whereas the single umbilical vein brings the blood in. So that is what happens during the fetal life. So after fetal life, you know, this part can't happen. So then what happens is, then this umbilical vein becomes a ligament of teres, whereas the umbilical arteries convert into the medial umbilical ligament. So those two are the vestigial organs. So then what happens is, there is no blood coming from here. So the liver will have two blood supplies, one from the hepatic artery and the other one is the portal vein. So that will be there, the IBC is there. So then the foramen ovale gets closed, so all the blood coming to the right side will remain in the right side, whereas the blood in the left side comes from the pulmonary tree. And this part as well as this part now gets closed. So if you look at the close in the heart, of course you will remember that this is how the intra-heart transfer of blood happened. So this dark blue came with this thing, purple is less saturated. So then majority of blood goes into the descending aorta. That afterwards what happens is, this connection has closed, whereas this connection also has closed. So blood from the whole of the body comes into the right side, goes into the pulmonary trunk, goes to the lungs. From the lungs it enters back into the left atria, left ventricle, and goes all around. So you can see this is not two parallel system, but one in one working in series. Now the age of presentation will depend on the type of the lesion. There are certain lesions which will come or show symptoms in the very early stages of life, first few days of life. Then others in the infancy, first year of life. Some lesions may be detected in childhood. And of course, there will be other lesions which will be detected even at adult life, especially ASDs. Nowadays, of course, that is less happening. But in the good old days, the pre-echo era, where most of the diagnosis was based on the auscultation as well as the chest X-ray, they were detected mostly during pregnancy in females, because you know the blood volume increases in females, and as a result of that, during pregnancy, the murmurs would be more visible. So then during that period, they will detect them. So that is what really happens. So the presentation is antenatal diagnosis. Now you all may have heard what we call an anomaly scan. So you can see the congenital heart disease diagnosis, how it evolved. Initially, it was with the color of the appearance. Basically, if somebody was cyanosed, then they would have suspected. But with the invent of the stethoscope, we began to hear different sounds. Then the ultrasound scan or the X-ray came. The X-ray helped a little bit more. Then ultrasound scan in the form of echocardiography came. Then it gave a good picture. Then, of course, with that, or a little bit earlier than ultrasound scan, probably around the same time, came the cardiac catheterization. And so all those were done in the postnatal life. Now you can see we have gone even into the antenatal life. And what we do is a scan, what we call the anomaly scan, around 18 to 20 weeks to detect any congenital abnormal. So that is one way of seeing this. So the advantage of this is that these children can be transferred to a tertiary center where they may need immediate medication. It may be maybe even cardiac surgery or certain medication like prostaglandins or adenosine or whatever. That depends on the lesion. You may sort of give them. So that is one way. Then the other thing is what we hear as what are called murmurs. So murmur means a turbulent flow that would generate a noise which would be heard either due to a lesion which is within or in the in the close vicinity of the heart. So a pathological murmur is when there is some form of abnormality that the pathology, if there is underlying pathology, because there could be sometimes normal murmurs also, or what we call actually a non-pathological or benign murmur. So that can be, the best example is during pregnancy. Sometimes you will hear a murmur because the blood volume in the mother has increased now. So large volume of blood try to pass through certain places, and then that will cause them to develop a noise. Now that is where
Recording stopped. Recording in progress.
hello.
Yes, sir.
Did you hear me or did you lost me at the point?
You got disconnected, I think, sir.
Around what time?
When you explain the physiological murmurs in pregnant women.
Did you see this one? Did you get?
We can't see the screen now, sir. I think you have to share again.
Sorry. What was the last thing you saw? Do you see now?
Yes, sir, you can see.
Right. Now, what did you see? Something is wrong here. Hold on. Now, can you see this one?
We can see the slides, sir.
This is not moving. How are you open to these things? Now, do you see this one? Did you all see this one? Which
Yes.
one you all saw?
It's the one with the like, sir, you were explaining like the anomaly scan and the physiological murmurs. This one, yes, sir.
Right. So, right. Okay. So, did you hear? I mean, right. So, the anomaly scans you heard.
Recording in
the
progress.
pregnancy, there can be increase in the volume of blood. So as a result of that, a large volume of blood is going through a normal heart. Or if there is sometimes large gush of blood caused by thyrotoxicosis, because there will be an increase in the contractility. As a result of that, they will be having a large volume of blood moving. So that is an abnormal volume through a normal orifice. Then there can be abnormal direction. So the blood was meant to pass from the left atrium to the left ventricle. But with the contraction, due to the incompetency of the mitral valve, the blood, apart from going through the aortic valve, it is part of that will be going through the mitral valve also. So it was going in the retrograde direction. So you will hear an abnormal sound because it is now going in the abnormal direction. Or there can be abnormal connection. For example, a VSD, which was never meant to be there. So when blood is moving through the amount, that will happen. Then it can happen even in the patent ductus arteriosus. If the patent ductus is there, then it will give rise to that flow happening through a connection because it was not meant to be there. So these are the main areas of where you will listen the murmur or the related to the heart valve. So you can see, although it is on the right side, you get the aortic valve. On the left side, pulmonary valve, because in your mind you see the left heart is mainly the left ventricle and the aorta, but the right heart is the right ventricle and the pulmonary trunk. But in the body, of course, because of the twisting and how they are laid in direction, these are the places where you will be hearing these murmurs. Then you can hear the tricuspid valve in the lower left sternal edge, and little bit deviated to that in the toward the mitral valve would be heard mainly in the fifth intercostal space, more closer to the clavicular line. So those are the main sites where you will be hearing. So aortic and pulmonary valves together will make the second heart sound, and tricuspid valve and the mitral valve closure would make the first heart sound. Y'all are with me now? Hello?
Yes, sir, yes.
Yeah, because I just wanted to make sure that the connection is not broken. Right. Now, the presentation, when you see one of the ways that they can present with changes in color. And I hope you all know what is meant by cyanosis. That is actually blue discoloration on the skin. But why does it happen? Only when it will happen is when the hemoglobin concentration in the blood is more than 5 grams per deciliter. This happens because the oxygenation of the blood is not happening, and or in the lungs, or if there is right heart of the blood is mixing with the left heart side blood. So that means the right heart blood bypasses the lung and straight away enters into the left heart of the of the heart. So when they bypass, there is no oxygenation. As a result of that, this will happen. So this is one of the cardinal, one of the groups of congenital heart diseases, whereas the others would be acyanotic heart diseases. So this is one striking thing that would happen, which you can see. Then the other thing is the heart may begin to fail. Now, the easiest way is any organ, if you listen here, it has a failure. That means you just have to find out what are the functions of this organ, and those functions are not happening. So like that. So when there is heart failure, means its function is to get the blood away from the peripheries to the heart and pump the blood out of the heart. So if it is not getting the blood which is available from the peripheries towards the heart, that means there will be edema in the periphery. Whereas if it is not pumping the heart blood to the peripheries from the heart, that means the functions can't happen. So if there is less blood going into the brain, the person will feel lethargic. If less blood is going into the muscles, the person will feel very tired very fast. So like that, you will have all these problems related to the lack of functions of the blood being sent to the peripheral tissue. So that will be the feature, that would be the features of heart failure. So edema in the dependent part where the blood is not collected back or brought back to the heart, and blood because not being sent to the peripheries, then those organs will fail. So if blood does not come to the kidneys properly, there will be improper filtering of blood, and then reduction in the urine output as well as collection of other material in the body. So like that, this can happen. So that is how you can remember what are the features of a failure of an organ. So those are the main things. So you will see these patients, especially when you're doing pediatrics, because most of the patients do get operated when they come to older age, when they are seen in adult wards. So when you begin to do the appointment, or if you have time, you can go into the cardiology unit. But of course, the cardiology unit may not have. Only most of them are now being operated at later age way. So then once you are doing the pediatric appointment, you will see, especially when you are doing pediatric, or if you do the gyn and obs appointment, and you begin to see the postnatal side of the ward, where you will see the newborn babies with this. So if you look at some of the common congenital abnormalities, as I said earlier also, there can be acyanotic, where there is no cyanosis, and mainly they will present with a heart failure or incidental detected murmur, and they can be rarely asymptomatic also. Or it can be a cyanotic, which is quite obvious. Even the parents will see that, notice that, and they will bring the child to the medical facility. So they will be discoloration. Membranes also there could be skin as well as mucous membranes. So if the mucous membranes are discolored, then we call it as central cyanosis. That is mainly the tongue and the oral cavity and the lips. But if sometimes when the blood is moving very slowly, you can also have bluish discoloration of the fingers and toes as well. So that is peripheral cyanosis. So when you have peripheral cyanosis, it could be either a congenital heart disease, or it could be a peripheral cold circulation, cold peripheries with poor circulation, or it can be, or if it is only you are having central cyanosis, of course it's mainly a heart or a lung problem. So then you will have the murmurs, then you will have heart failure features also in cyanotic heart diseases. So there are few types. I am sure that during your embryology in anatomy, you would have also heard these terms. So ventricular septal defect, as the names say, there is a septum between the ventricles and there is a defect. There is a patent ductus. So the ductus is patent. There can be pulmonary stenosis. Then there can be atrial septal defect. Interatrial septum is defected. Coarctation, aortic stenosis, and these are some of the other things. When it comes to cyanotic heart diseases, you will see that there is the Tetralogy of Fallot, transposition of great arteries, truncal arteriosus, anomalous pulmonary venous drainage, and univentricular heart. Of course, we can't forget about those. The last one. You just have to know the basic underlying defect of these, and then you can actually work out most of these things. So this is how a VSD will appear, where there is a defect between the right and left ventricles. So blood, as you know, the pressure is higher on the left side than the right side. So when the ventricles simultaneously contract, apart from blood going through the aorta, part of the blood will come onto the right ventricle. So what will happen here is that there will be a murmur because the pressure gradient is very high, and there will be a murmur generated at this point. But as well as some of the blood is coming from the left side will enter into the pulmonary tree. So there will be a large volume of blood now going into the lung than normal, because part of this is also coming here. So there will be a murmur throughout the systole, that is between the first heart sound and the second heart sound, because the first heart sound is when this begins to close, second heart sound is when this begin to close. So when this begin to close means when the ventricles contract, and throughout that period it will be there till the the pulmonary valve or the aortic valve closes. So then there can be heart failure also, because you can see less blood is now pumping out of the left ventricle, because part of it be pumped out onto the right side. So then naturally there can be problems in the periphery depending on the size of this. If there is a large cavity here, if more blood comes to this side, less blood will go to the aorta. So then there will be heart failure features. So there can be heart failure, risk of endocarditis, because there is this blood. Now have you all learned about endocarditis? Not yet? Hello? Hello? Do you all hear me? Students?
Yes, sir. We can hear, sir.
Yeah. Now, have you all heard about endocarditis?
Yes, sir.
Yeah. So now what happens is there is a blood that can be jet out, where there will be coming in a pressure, and it can damage this part of the endothelium, and there can be organisms staying there and causing vegetations and give rise to endocarditis. Then as a lot of blood is going into the heart, to the lungs, there will be what we call wet lungs. And when there is wet lungs, they can develop some amount of infections. Then the pulmonary hypertension, because I said a large volume of blood is going. Now in a normal tube, a large volume of blood, when it goes, it stretches and causes pressure increase. So what we call pulmonary hypertension. So these are some other things. So you can work out these things. So the jet of blood can damage this, can cause infective endocarditis. Less blood is going to the tissues, because the aorta gets less blood. So there will be heart failure. Then more blood is going through the pulmonary trunk. So more blood to the lungs. Because of that, lungs will be more hyperemic, more wet. So infection can sit in. Then as more blood is going through the pulmonary veins, they will have increase in pressure and they can develop pulmonary hypertension. I hope those are clear to you. And most of these VSDs will close on their own. Then the ASD, you can see again the similar thing, but at a lower pressure. So the pressure is not very high. A certain amount of blood will come. But again, the volume will increase here. And there can be less amount of blood going from the left ventricle to the aorta. So there will be a murmur here is very, very minimum. Why? Because the pressure gradient is less. But there is a large volume of blood now going through a normal orifice. So large volume through a normal orifice causes a systolic murmur, because there is an increase in the volume. Then of course you can see now there is large, now these two valves, the aortic and the pulmonary valve closure, will causes the second heart sound to occur. Now if they happen together at the same time very closely, it will be a single heart sound. Now you can see less blood is coming from the left ventricle to the aorta. So this, as it will be kept open till the left ventricle is empty. Once it empties, it will close and make the noise. Then on the other side, there will be more blood than it should be usual. So while this is closing, this still keeps on functioning with pumping out blood. So the right side will take a little longer to close because there is more blood on the right side. So this will close early, this will close a little later. Because of that, what will happen? There will be the second heart sound will be heard as two different distinct heart sounds. What we call a splitting of the second heart sound. So there will be a fixed split. So there will be, actually you will hear the second heart sound is not as a single one, but as a two distinct heart sounds, but very close to each other. And with time you will understand, appreciate the nature. So that is how the fixed split, which we consider in the ASD, originates. The risk of developing heart failure and endocarditis is very minimum compared to a BSD. And these usually have to be closed by surgery or using a device where without opening the heart, they can do a closed surgery. Then of course the PDA, you can see that what will happen is it is very early in life, continuous murmur coming into the aorta, and the pressure in the aorta is higher than will also come to the pulmonary. So the more blood will now go into the lungs. So as in a VSD, so the similar things that happen in a VSD or to some extent in a ASD could also happen here because there will be continuously blood moving into the pulse. But of course it is happening at a different level, because of that the second heart sound will not get affected. But you know, always the pressure in the aorta, whether it's systole or diastole, is higher than the pulmonary pulmonary artery pressure. So because of that, there will be continuously throughout the heart cycle between the first heart sound and the second heart sound, as well as the second heart sound and the first heart sound, it will be continuously there. Of course, the intensity will vary because with, you know, the systolic blood pressure of the aorta is 120, which will drop to 80. So from 110, 20, it will pump blood to about 15 or 20 here. Whereas here in during diastole, from 80, it will pump down to about 10 millimeters of mercury pressure in the diastolic pulmonary artery. So that way it will be, so that is why you get a continuous murmur, which we call as a machinery murmur. So again, because of this, there can be damage to this endothelium because of the high pressure. So it's not endocarditis, it is endoarteritis. Then there can be less blood going out because some of the blood is now going back into the pulmonary. So again, the heart will fail also. Then more blood is going into the lungs. Because of that, it can cause hyperemic and wet lungs, so the infections. Then of course, more blood is now coming into the pulmonary circulation. Because of that, you get pulmonary hypertension also develop. So that is how it will happen.
Recording stopped. Recording in progress.
So most of them will need surgical correction or device closure. Then the coarctation of aorta, when the ductus closes, sometimes it may cause a pulling of the aorta. So then there will be a contracture or stenosis occurring in this aortic descending aorta, which we call as the coarctation of aorta. So it usually happens after giving the main blood vessels to the heart and the upper limbs. Then this part will be there. So the clinical ones are commonly in early life: collapses, heart failure could be there, because you can see again the blood is not coming down beyond this obstruction to the lower part, kidneys as well as the lower limbs. Then the femoral pulses will be very weak. Blood pressure will be high. Why the blood pressure is high? One thing is because initially there will be more blood going to the upper limbs than the lower limbs. And on the long run, what will happen as less blood is coming to the kidneys, the renin-angiotensin system will operate because the kidneys think there is a hypovolemic state due to hormonal reaction. There can be a risk of death and there can be hypertension later in life. So surgically it has to be corrected. Now what happens is you can see this part is there, but you know the subclavian and then the intercostal arteries are there. Now these come partly downwards and connected to the subclavian. So they will begin to feed these anterior parts, and then you can see there will be collaterals developing, or the intercostal vessels begin to enlarge. And as a result of that, you can see, because when the blood vessels enlarge, we are talking about growing children, their ribs are very cartilaginous, they are not ossified well. So then they will have difficulty in growing in the normal way because there is a big artery preventing it growing. And as a result of that, you will see the notching occurring in the ribs posteriorly. And if there is a poor femoral pulses, of course, this will not occur in a newborn baby. It will be later in life that you will see in 3-year-old, 4-year-old, 5-year-old. When the ribs are getting mature, you will see that there will be a notching in the ribs. So this is happening because now there is blood is trying to come through this way and enter into the aorta. So to the internal mammary, it will come this way, internal mammary anteriorly, then it feeds the intercostal vessels, they go and they actually originally they have to come this way around, because these are the more pressure increase, high pressure places. But the pressure in this part is high, so then it begins to pump blood in the reverse direction. So as a result of that, these intercostal vessels increases in size, and then they will make an obstruction to the growth of the ribs and causes notching of the ribs. Then going on to the cyanotic congenital heart disease group. So mainly I have discussed the three main things, the AST, BST, PDA and the coarctation. That is more than enough for you all at this stage. And with time you will be able to read around more. Then when it comes to the Tetralogy of Fallot, that is less blood is now going into the lungs and getting oxygenated and coming back into the left side of the heart. Now one of the common ones are Tetralogy of Fallot. So there is, as tetralogy, there is 4 things that are there. So what are these 4 things? One thing is that there is a VSD. Then there is a pulmonary stenosis. Because there is a VSD, it's a large VSD, and there is because the pulmonary trunk is also small, the aorta has got pushed to the right side. So as a result of that, the aorta overrides the right and left ventricle both, which we say if the overriding is more than 50%, it is significant for Tetralogy of Fallot, or we call it as override. More than 50% of this aortic orifice is on the right, going on to the right side. So you can see that that has happened. Then of course, because of this pulmonary stenosis, the right ventricle try to contract vigorously and force the blood through the pulmonary trunk. Now what will happen when there is resistance for the movement? The muscle will begin to contract more vigorously. As a result, what will happen is it will be pumping against the force, and then the musculature will hypertrophy. So you will have the right ventricular hypertrophy. So the 4 parts of Tetralogy of Fallot is that they will have an ASD, they have a pulmonary stenosis, then due to the ASD there will be overriding of aorta, and because of the pulmonary stenosis there will be right ventricular hypertrophy. So that is the Tetralogy of Fallot. So in that you can say it presents usually in the later life in the sense second part of first year or second year, third year life. So there will be bluish discoloration, there will be a murmur. So the murmur will be a soft murmur where normal volume of blood sometimes, or could be a little bit of large volume, going through a abnormal orifice because there is a mitral stenosis. So that is where the VSD is very large. It will not generate a murmur because the pressure gradients are very low because there is constant mixing of the both sides. But the blood volume that is going through this abnormal valve will cause the murmur. So then, of course, there will be other problems, like because less blood is going to the lungs will not develop properly. So then there will be overall hypoxia. Then there will be cyanosis. Then because of the cyanosis or hypoxia, red blood cells will produce more. So you will get polycythemia. And sometimes what happens is the blood now from the right hand side comes into the, now the one thing you should remember is that the lung has also cleaning of blood. So that function will be lost because the blood is less amounts is going to the lungs. So more blood will be going into the, or the deoxygenated blood will be entering into the aorta, and they can also have various microorganisms. So they can go to the brain and cause cerebral abscesses. So those are some of the complications you would get in Tetralogy of Fallot. Then, so you will have what is called a boot-shaped heart because this is very narrow. The whole, now this pedicle is formed by the aorta and the pulmonary trunk. So they will be very close together because the pulmonary trunk is very narrow. So as a result of that, you get a narrow pedicle. Then you have the right ventricle here, which enlarges. So it pushes the apex up. So you get a boot-shaped heart. That is one main thing. So management, I'm not going to deal very much here. So the main thing is that you have to do surgical correction. And the important thing is because they have polycythemia, you have to prevent them getting dehydrated. So a child with cyanotic heart disease, if they develop diarrhea, they should hydrate the child very effectively. If there is vomiting is not settling easily, it is advisable to take to a hospital quickly and start an IV drip because otherwise his blood will be more concentrated. The PCV will go up into 70s, even 80s, and as a result of that, they will have circulatory problems and then they can develop clots and then there will be infarctions. So it is important that you know that. In transposition of great arteries, you can see the blood coming from the IVC is going back into the aorta and going all around the body. So you can see here it will go, it comes through the IVC, gets back. Whereas the blood from the left ventricle goes into the pulmonary trunk, goes into the lungs, come back again into the right. So you can see these two systems keep on going parallel to each other. So one heart does not mix its blood with the other side. So what will happen in these children then? Can anybody tell me quickly? So the blood from the SVC, IVC enter into the heart, goes into the aorta, gets back again into the IVC, SVC. Blood from the left side of the heart comes into the pulmonary trunk, goes to the lungs, comes through the pulmonary veins again into the left side of the heart. What would happen? Such child. Anybody? Anyone there?
So the child will have serious cyanosis?
Well, he will be centrally cyanosed. Okay, more than that. Can they survive?
Not without surgery, sir.
Because there is no oxygenated blood now coming to your hand or feet. So
Sir,
the blood
is it incompatible with life?
Exactly. So to be compatible, what is needed? To be compatible, what it is needed?
Surgery, sir?
Patent ductus arteriosus.
Yeah, there should be a connection between the right and the left. There could be a ASD, VSD, or a patent ductus arteriosus. Right? So these type of children who become cyanosis the day one, they may need to either undergo surgery quickly. So what they were used to do was they put a probe and try to create the AS, because now the interatrial septum is still, foramen ovalis not fully closed. So they can pull out a flap and create it, ASD, or now we have what are called prostaglandins. When we give a prostaglandin infusion, that will, what happens is that will keep this ductus open. So then the surgeons can slowly go and do what is the surgery you think you should be doing. They should be doing. What is the surgery they should be doing? What is the easiest surgery? Anyone? Quickly. What do you think? Do you all with me? Do you all hear me?
Yes, sir.
What is the corrective surgery you think should be done? Come on. If somebody has fixed these tubes wrongly, what do you do? Sorry? Go ahead, say it.
Get into the right position, sir.
I didn't hear you.
They have to be brought back to the right position, sir.
Yeah, so you remove them from where they are and refix it to the correct way. What we call arterial switch operation. So this will be taken out and fixed here, and this will be taken out and fixed here. So sounds very simple, but of course little complex, but it is done in this country under 1 month of age, because otherwise you can't go on for long period, right? So that is it. So you can see the names itself, you can remember, transposition of great arteries. So then what will happen is, again, these two will be close together because they are now in different positions, because now the broadness of this is less. So then you get this clinical chest X-ray, what we call as a egg on a side, because you can see this as an egg with a small pedicle, which is almost hidden with the shadow of the vertebral column, and this is what is called the egg on a side. So the prostaglandin will help to maintain the duct patency. Sorry, till the heart surgery is done. Then there is something called anomalous pulmonary venous drainage. Sorry. So the names as it is says, what can you figure out by the words anomalous pulmonary venous drainage? It is just simple English. What do you think?
There's a problem in the pulmonary venous drainage, sir.
Pulmonary veins are
Drain to the wrong.
wrong. What?
Two of the veins drain into the right atrium.
Yeah. Two of them are draining into right atrium, two of them are draining into. So it can be different. So when you say anomalous, now we have 4 pulmonary veins. No? The 4 pulmonary veins can in different proportions fix into these. So it can be total anomalous pulmonary venous drainage, where these two also go and fix here. And then, so again, it is just like the truncus arteriosus, where the blood has come in from here, goes through the pulmonary vein, pulmonary artery, goes to the lungs, and comes back in the pulmonary vein into the right side. Right? So it is not pumping out blood away. So for that to happen, to survive, then of course there should be opening between again the right and the left heart sides. So because otherwise this blood will be coming here, coming back through this, coming into this side if it is total anomalous. But this one is partial anomalous. So this one will have a little bit of more cyanosis, weakness of the heart, because less blood is now coming to the aorta that way. So you can have total anomalous pulmonary venous drainage or partial anomalous pulmonary venous drainage. So these both are cyanosis depending on the degree of the anomalous number of anomalies that they have, or the number of pulmonary veins fixing into the aorta. Fixing into the right atrium and the right ventricle, right atrium and the left atrium. So it is because of this, because now more blood is now coming into the, because the whole of the IVC, SVC comes into the right atrium, then part of the pulmonary veins or totally a part of the pulmonary veins bring blood into the right atrium. So the right atrium enlarges, and then you can see the ventricles are in the same size or more. So because of the enlargement of the, it is more than hypertrophy, it is enlargement, dilatation of the atria. So as a result of that, the upper part is also large and the lower part is also large with narrow middle, it is narrow. So this is what is called the figure of 8. So you can see either it is as 8 or it can be something like what is called the snowman. So we don't have snowmans in Sri Lanka, but of course we have the 8. So it look like figure of 8. So either one is the characteristic. Now what has happened is most of this time we don't take these X-rays. We do get an echo and straight away they undergo cardiac surgery because of this characteristic radiographs we don't see today. But this is the appearance. So pulmonary hypertension is where there is, I said, any blood vessel contains more blood will develop increased pressure. So when there is left to right shunting, more blood is coming into the right side. So blood flow increases to the right ventricle, and then pulmonary blood flow increases. So the initial stage we call is hyperdynamic pulmonary hypertension because there is more volume of blood. The dynamicity, the movement is increased. So that's why we call pulmonary hypertension. So this is reversible. But what will happen is when somebody keeps on having high blood pressure, the blood vessels will begin to react. So as a result of that, the blood vessels will become hypertrophic. Their musculature will become harder and harder. So as a result of that, they will develop what is called obliterative pulmonary hypertension. Now the blood vessels are just like a Eslon tube. Now initially it was it was like a rubber tube, like a bicycle tube, where you can pump and you can inflate and you can distend it. But later on what will happen is because of this distension, the musculature, the media, which has smooth muscles, will hypertrophy and become rigid. So then what will happen is it will become like a rigid Eslon pipe, which it will not change its, not malleable, which not change its shape. So that is called the obliterative pulmonary hypertension. So then of course it is irreversible and you can't do anything. Then of course you have to put a new lung or lung transplant have to be done. So this is the 2 stages of pulmonary hypertension. So you have to corrective surgery should be done at the early stages of pulmonary hypertension. So we can pass this. Then there can be little bit of dextrocardia, where livocardia is more of the heart is onto the right side while it is maintaining, but dextrocardia is actually the heart is predominantly in the right side, and that of course can be part of a situs inversus, situs solitus, or it can be part of a situs inversus. So advances, what has happened is now we diagnose early. As I said, It's not even before birth they can be diagnosed, and we can have non-invasive diagnosis like echocardiography. Corrective surgery of complex heart diseases are also done very well, because what we have this, what is called the lung bypass machine. So we can connect the person to the a lung machine and do the surgery. In the good old days, they reduced the metabolic rate. They did not stop the heart. They brought the temperature to a very low degree. So the beating of the heart was at 10 or 15 or 20 beats per minute. And they were doing the surgery while the body was cool. So the metabolic demand was very low. But now, of course, they can send direct the IVC, SVC blood as well as the blood to the lungs, to the lung machine, and get the blood back and send it through the aorta to the rest of the body. Then use other simple procedures to treat some conditions like device closure. Overall disease morbidity and mortality has reduced very much. So congenital heart disease, you should remember, is the structural malformation in infancy and childhood, and it is the commonest congenital problem or organ that is affected. Most of the etiology is not known. VSD is the commonest lesion, individual lesion wise VSD. Then mode and age of presentation vary. Some are presented in very, very early stages, first day, second day, third day. Some, of course, even as adulthood during pregnancy or any other physiological body changes. Then mortality has come down to a great extent. Right. Any questions?
Recording stopped.
I have recorded it. I will try to upload it, but not 100% sure with what happened in the between. So, are there any questions?
So could you upload the lecture slides to the LMS?
Sorry?
Could you upload the lecture slides?
Yeah, I will try to get it uploaded. Okay?
Thank you.
Right. Okay. Right. Thanks.